Spinal Manipulative Therapy for Adolescent Idiopathic Scoliosis. Scoliosis is a condition that would logically seem to respond to chiropractic management with the focus on optimum spinal biomechanics and curve structure. Yet, this complex abnormality has a range of causes that may result in biomechanical changes, but may inherently not have their origin in simple biomechanical faults. Specifically, idiopathic adolescent scoliosis is by definition an abnormality without a known cause. Predictability for which curves progress has improved, but it's still difficult to be accurate in all cases. This imperfect science makes decisions regarding whether to use bracing, surgery, or conservative options all the more complicated. So given chiropractors are often sought out by concerned parents for their child's scoliosis, or if it is inadvertently discovered on physical exam or x-ray, what do we know about the success of chiropractic management? A new systematic review brings us up to date with what has been studied and what we do know and don't know at this point. The title is Spinal Manipulative Therapy for Adolescent Idiopathic Scoliosis, a systematic review published in Journal of Manipulative and Physiological Therapeutics in 2017. But before we summarize the findings of this review, let's first start with defining adolescent idiopathic scoliosis. Let's start with what it isn't. It's not due to an identifiable cause. It's not an adult curve, and it's not a transient curve due to muscle spasms secondary to pain. Congenital defects are generally apparent on X-ray or other imaging. These include two general types: either failure of segmentation, such as a unilateral bar vertebra, or failure of formation, such as butterfly vertebra. These are not responsive to conservative care. They are unresponsive to any attempts at applying the principles of Wolff's or the Hütter-Volkmann law, and will not respond to any form of bone stimulation. Scoliosis caused by these defects is a permanent feature unless surgically corrected. It's important also to attempt to rule out some conditions related to or causing scoliosis, therefore not idiopathic. These include neurofibromatosis, Marfan syndrome, Ehlers-Danlos syndrome, and some intraspinal abnormalities such as tumors, tethered cord, and syrinx. Remember that adolescent idiopathic scoliosis is a three-dimensional deformity. It's defined as a coronal plane Cobb angle greater than 10 degrees, but is further defined as a lateral spinal curvature in the frontal plane, abnormalities of physiological spinal curvatures in the sagittal plane, usually a hyperkyphosis in the thoracic spine, and axial rotation of vertebra in the transverse plane. These changes over time apply pressure to growing epiphyses, causing restructuring that is permanent, the structural component of adolescent idiopathic scoliosis. Most importantly, in children and adolescents, consider that the scoliosis is not idiopathic when painful. It's likely due to pain and the resulting muscle spasm. It seems counterintuitive to chiropractors and other healthcare practitioners, but in fact, pain is uncommon as a presenting complaint for idiopathic scoliosis and usually indicates a transient scoliosis due to muscle spasm. So what may appear to be a miracle cure of idiopathic scoliosis may in fact be resolution of a transient effect. In other words, resolve the pain, resolve the muscle spasm, correct the curve. But beware that there are other causes of these painful transient and often acute angle scolioses, such as osteoid osteoma. To place our discussion in context of society in general, know that the prevalence of AIS has been reported to be between 0.47% and 5.2%, but that's an average range. Let's look at prevalence broken down by specific factors. Here we see prevalence based on the Cobb angle. The prevalence of curves more than 10 degrees is only 1.5 to 4.3%. Those more than 20 degrees, 0.3 to 0.5%. And for those greater than 30 degrees, those most likely needing bracing or surgery, the prevalence is only 0.2 to 0.3%. Not all curves progress. Here's a graph illustrating the percentage of curves that progress based on the riser sign or Cobb angle at the time of diagnosis. For a riser sign 0 or 1, 22% of curves from 5 to 19 degrees progress. 68% of curves from 20 to 29 degrees progress. For a riser sign 2, 3, or 4, 1.6% of curves 5 to 19 degrees progress, whereas 23% of curves 20 to 29 degrees progress. This natural history must be acknowledged when claiming success in the management of scoliosis. Lack of progression and even minor improvement may simply be this natural history likelihood. And to get a more complete picture, let's add in the progression percentage based on age and severity. Note that most progress if they are 20 to 29 degrees if found in 10-year-olds or younger, and about half for small curves and 100% for larger curves. And the reverse, very few progress when found in those 15 years old or older, 4% for small curves and 16% for larger curves. In determining the success of scoliosis management, one important measurement is the effect of postural deformity on patient report of self-image and other psychosocial aspects of cosmetic deformity. It has been shown that in the long run, patients are less often affected by functional issues such as respiratory compromise, but more affected by the cosmetic distortions of postural deformity, as we will see. If detected early, it has been reported that there is a threefold increase in the number of patients who could be conservatively treated for scoliosis, thus decreasing the percentage of patients who required surgery using standard guidelines. There are a number of methods used for AIS detection. In addition to the Adams test using forward bending to determine rotation using rib hump angle, there is the addition of a scoliometer, which is a fluid-filled inclinometer. This device has been digitized into a number of iPhone and Android apps. This is incorporated as part of the Adams test. Here we see some of the variety of scoliometer applications available. Some have distinctions or advantages over others. For example, the Scolio screen uses an optional clip-on device for the bottom of your smartphone that mimics the shape of a standard scoliometer. The Scolio track allows you to store patients' data such as age, height, weight, and a photo for that visit against a postural grid. It even allows you to graph the results over time. Specifically, a study in 2014 evaluated an app entitled Validity and Reliability of the iPhone to Measure Rib Hump in Scoliosis, published in Journal of Pediatric Orthopedics. In summary, the iPhone scoliometer and scoliometer with mathematical formula methods for the measurement of postural deformity in AIS were associated with moderate or strong levels of evidence and overall demonstrated moderate to high reliability and generally high criterion validity. Other methods were associated with limited levels of evidence and not readily available. The application of findings is based on the general rule that a rib hump angle of greater than 5 to 7 degrees of rotation equates to a structural curve of about 20 degrees. Now to radiographs. For an evaluation of the lateral bend severity of scoliosis, the Cobb angle is determined. Other methods include using the scoliometer and Cobb angle coupled with the riser sign, the Nash-Moe method for determining rotation, and the Grulich-Pyle atlas comparing wrist radiographs indicating skeletal maturity. And also there's lab testing of genetic markers indicating the likelihood of progression. Surgeons use classification systems, such as King, Lenke, and Conrad, among others, to determine the flexibility and rigidity of the curve, primary versus secondary curves, and the extent of curve length to make decisions about the most appropriate surgical correction. Now to management. As a reminder, there are standard management guidelines for AIS. Observation is recommended for small curves less than 25 degrees. Bracing or special intensive inpatient rehabilitation for curves is recommended for those between 25 and 45 degrees, and surgical correction is recommended for curves that have progressed beyond 45 degrees. And for bracing, there is still much debate. This is complicated by many design types and claims. However, for high-risk curves, bracing is believed to be of value. Yet, there are still many compliance issues, including the time spent with the brace on, restricted range of motion with activity, cosmetic concerns, and discomfort from pressure points at points of stabilization. Now back to the systematic review on manipulation, the focus of this presentation. So how is manipulation viewed as a treatment option? It might be surprising, but guidelines developed by the Scoliosis Research Society suggest that spinal manipulative therapy may be beneficial in the management of adolescent idiopathic scoliosis. The outcome measures by the Scoliosis Research Society and Society on Scoliosis Orthopedic and Rehabilitation Treatment were used in determining the success of treatment in the systematic review. The primary outcome was the change in the Cobb angle, but secondary outcomes included aesthetics, pain intensity, physical disability, quality of life, and adverse events. Out of 143 potential studies, only 19 full-text studies were retrieved and considered for inclusion, and only 4 satisfied the eligibility criteria and were included in this systematic review. There was only 1 RCT and 3 non-randomized studies. In one study without a control group, SMT combined with soft tissue therapy resulted in a mean reduction in the Cobb angle of 8.8 degrees after 4 weeks and 10.2 degrees after 8 weeks. In another study involving SMT combined with soft tissue therapy, no change in the Cobb angle was observed in the control group after 6 months, whereas the intervention group experienced 0, 4, and 7 degree Cobb angle reductions in the thoracic, thoracolumbar, and lumbar regions respectively. In the remaining study involving SMT, the mean reduction in the Cobb angle was only 0.5 degrees in a period ranging from 6.5 to 28 months subsequent to baseline. Note that these improvements in Cobb angles are mainly within the standard error of measure, which has been determined to be about 5 to 7 degrees. In another study, there were 2 independent groups. One group involved the use of osteopathic manipulation, soft tissue therapy, traction, and acupuncture, and exercise was the approach used in the comparison group. For those aged less than 12 years, 71.2% of the untreated group experienced an increase in the Cobb angle greater than 5 degrees, whereas 46.6% in the intervention group experienced the same degree of progression in the Cobb angle. Among those aged 12 to 14, 55.8% of the untreated group experienced an increase in the Cobb angle greater than 5 degrees, whereas only 30.5% in the intervention group experienced the same degree of progression in the Cobb angle. Note there were a small number of participants in 3 of the included studies. Now let's look to another perspective with regard to non-surgical management of AIS. Published in Spine in 2017, the title is SRS 22R Scores in Non-Operated Adolescent Idiopathic Scoliosis Patients with Curves Greater than 40 Degrees. This study questions current beliefs, summarized as, quote, studies inferred that larger non-operated adolescent idiopathic scoliosis curves would result in significant pain and cardiopulmonary compromise, but when more appropriate inclusion criteria were considered, these medical risks were not substantiated, unquote. It is interesting that as far back as 1969, long-term follow-up studies have not shown that suspected serious consequences occur. And more recently, in 2015, there was another study confirmation of this in Natural History of Adolescent Idiopathic Scoliosis in Skeletally Mature Patients, a critical review published in the Journal of the American Academy of Orthopedic Surgeons. So, what was the purpose of this study? It was, quote, to document SRS 22R functional outcomes data for this cohort, those with scoliosis in a surgical range but not treated surgically, at intermediate term follow-up, unquote. Also, the study cohort's SRS 22R scores were contrasted to the postoperative scores of a cohort of operated patients and the minimally clinically important difference consideration used to better understand any clinical differences between the groups. Let's review some of the demographic comparisons between the non-surgical and surgical patients. For the non-surgical group, there were 190 patients, 85% female, 22% used a brace, and the average age when the curve reached 40 degrees was 16 years of age. Average follow-up was 7 years, and the Cobb angle averaged at that time 50 degrees. In the surgical group, 166 patients were included, 81% female, and 26.5% used a brace. The average follow-up was 18 years. Preoperative Cobb angle averages were 60 degrees. However, postoperative Cobb angles averaged only 26 degrees. The scores for each group reflected no statistically significant differences in the pain, function, or mental health domains. Statistically significant differences in favor of the operative cohort were found for self-image and satisfaction domains, but was this clinically significant? The results of this study show that at an average 8-year follow-up, a single surgeon's patients with AIS curves greater than 40 degrees treated non-operatively compare favorably to a similar cohort of surgical patients treated by the same surgeon. Although there are small statistical significant improvements in self-image and satisfaction with the surgery patients, this may be of little real clinical significance in light of published MCID values. Now, because the chance of progression can be 50% if curves are in the 45 degree to 50 degree range at the time of skeletal maturity, with continued progression into adulthood of 1 to 2 degrees per year, most patients' parents choose surgery even knowing that the consequences of progression have not been shown to result in serious adverse medical events. It is important then to contrast the option of non-surgery with surgery. Early reoperation rates are reported as high as 12.6%, and reoperation has been reported for infection, draining sterile seroma, hardware issues, proximal and distal junctional kyphoses, add-in curves, late-onset deep metal pain, adjacent segment stenosis, sagittal malalignment, and neurological issues. Also, there is failure to meet the patient or family's cosmetic concerns. So taken as a whole, we know that there are few high-quality studies regarding manipulation for AIS, and the results are equivocal. The degree of improvement measured by the Cobb angle fits and in some cases overlaps closely with the standard error of measurement for the Cobb angle, yet this means many curves did not progress, but unfortunately we don't know if they would have without SMT. We also know that although there is progression greater in non-operated curves in general, the measures of patient self-esteem and other satisfaction measures are not clinically significantly different when compared to those who have had surgery. It is concerning that there are quite a number of chiropractors and other health professionals that base their advertising and practices on scoliosis correction. This is literally a potential for thousands of case studies or more sophisticated prospective studies, yet there is literally no indication that these individuals make the effort to study or publish their results. For that reason, and for the common practice of charging substantial fees for this treatment, patients should be wary of such claims. Decision-making is difficult for patients, parents, and doctors. The juggling and weighting of multiple factors that are in dynamic flux is frustrating, yet the main features are age of diagnosis, bone maturity indicators, and severity of curve. Constant observation for rapid progression is important to allow quick changes in management. Considerations of cosmetic deformity and self-image likely change over time but must be considered. When surgery is considered, adverse effects must also be included in a weighted decision. Considering that the natural history of adolescent idiopathic scoliosis is that few curves progress, surgery should be the rare exception.